Welcome to the next edition of invited faculty lecture from Hand to Shoulder Clinic. So today with us we have Dr. Karthik Selvaraj. He is from Coimbatore and he has done his MS Orthopedics from AIMS New Delhi. He has done his shoulder fellowship from Christchurch, New Zealand and Hamilton, New Zealand. He has done his trauma and reconstruction fellowship from Melbourne, Australia and Adelaide. He has been traveling fellow for APK, AAS and ESSKA. He is a director of KS Orthocare, which is shows his enterprising skills, and he is a past EC member for Shoulder and Elbow Society of India. Today he'll be speaking to us on clinical examination of shoulder. Not only clinical examination of shoulder, how to interpret your examination findings. So he'll enlighten us with that. Karthik, you're welcome. And you can share your screen and start with your talk.
Yeah, I think the screen is shared already. So first of all, good evening to all of you. I would like to thank Dr. Vikas Gupta and Dr. Akram. Both are my dear seniors from AIMS Delhi. It's a big privilege for having had this opportunity to talk to you all today. So I've got my fellows, ex-fellows also here. I think Sanjeev and Hariharan are here. I got other fellows who slowly will join. So let's talk about this. I'm just going to talk about how I go about clinically examining the shoulder. We all see a lot of patients in the OPD. So there's not much time actually before coming to a diagnosis. So I call what I do as a fast-track shoulder examination so that you come to a clinical working diagnosis within a couple of minutes of seeing the patient. So normally I would like to do this actually. So I call this a diagnostic clusters. So we can cluster a shoulder patient into one of these groups very easily, very easily actually. So normally these are the common diagnostic clusters you have in shoulder. So it's the primary frozen shoulder case, which is the most common patient whom you see in the OPD. Next is the cuff tendinosis, partial tear, bursitis, the subacromial pain patient. Then the third patient is the cuff tear patient. Then you have got the shoulder osteoarthritis, which is obvious when you get an X-ray. So that's like a straightforward diagnosis for you. Now then comes the instability group. That's where you have a little bit of a confusion. So it can be traumatic instability, it can be SLAP, it can be overuse, it can be a multidirectional instability, it can be muscle imbalance, scapular dyskinesis, elongated biceps. All this I would like to group as instability cluster because all these diagnoses actually have some component of instability in there. There is a muscle imbalance which actually leads to instability, which is the cause of pain. Then there are nerve lesions, like we normally know, all the nerves around the shoulder can get involved. You can have a deltoid palsy, you can have a long thoracic nerve palsy, you can have a accessory nerve palsy. These are also things which actually can be very subtle and you can easily miss them if you don't look for them. And then you have the AC joint pathology. You can have distal clavicular osteolysis or AC joint arthritis. So these are the basic diagnostic clusters under which I actually would like to group the patient in. So first thing I would like to rule out in a patient presenting with shoulder pain is cervical cause. So I would like to actually rule out cervical pain because we are just wasting time. It's not our patient. It needs to see some other doctor. So the easy way for me to rule out cervical cause is actually passive neck extension. Passive neck extension, if the patient has shooting pain, I know that this patient has other causes of pain other than the shoulder. There might be a coexisting shoulder problem, but I think the patient will put the hand here and have pain all the way from here. Are you able to see me as well?
Yeah.
Yes, Karthik. Yes, we can see you.
Yeah, we can see you.
So, the passive neck extension is one test for me to just exclude cervical problems immediately. So this is my sequence. So what I do basically is I make the patient stand. I stand at the back of the patient. I observe the active elevation, then perform passive neck movements, then perform passive shoulder movements. Then I do strength testing and special tests, palpation of tender points as well. So this is the sequence I follow. This takes about 1 minute to do, and this will actually give us the working diagnosis, and then you can do some special tests if you want to elaborate on what your diagnosis. So standing from the back, I think can make it a little attractive. Standing from the back actually is very, very beneficial and disturbing the patient. These are all statements which we regularly tell. This gives you a lot of information. Do not hesitate. If you suspect something at the back, don't hesitate.
I request everyone to please mute their microphones. Please, everyone, mute their microphones. Yeah.
So,
sorry, but
yeah, no problem. So this is I think some volunteer can answer if I can ask questions. Is that okay, sir?
Yeah.
So on the right hand side what do you find? That lady's picture. What do you find on the right hand side? This is the view from the back. This patient has presented with impingement.
Yes, sir.
What is it?
It is a winging of scapula right side.
Winging, excellent. So what winging is this?
So this medial border is prominent.
Yes. So what could be the nerve involved?
Sir, there is palsy of the muscles of the scapula.
Long thoracic nerve, sir.
Serratus
anterior is paralyzed.
Serratus anterior, fantastic. So it is serratus anterior palsy. The winging can be of two types. There is a medial winging and a lateral winging. So medial winging is usually because of serratus anterior palsy. This is how the scapula looks when you look from the back. Now, we have seen patients coming with serratus anterior palsy who have undergone several injections for impingement, because they will come with inability to lift the shoulder and pain. And when you don't examine the back, to look as if it is like it is impingement. I have had 20 and 21-year-old girls who have undergone subacromial decompression surgery because they didn't turn to the back and see the scapula. So this is something which you need to keep in mind when you examine the shoulder. So again, age can tell you a lot of things. If the patient is a young, so don't think about cuff-related problems in a young patient. 20, 25, even 30-year-old patients, very, very rare to have cuff problems. Okay, it's mostly instability related. Whatever cuff problem you have is instability related. Keep that in mind. Now, 35 to 50, it is instability. It could be instability, but it is actually early tendinosis, or it could be frozen shoulder. More than 40, 45, you get frozen shoulder very often. Middle-aged patients can be frozen shoulder, osteoarthritis. So any patient older than 80, don't think about frozen shoulder. You should actually rule out everything else before you confirm that it is frozen shoulder. So this is a patient, a 75-year-old patient. This is the X-ray. This patient underwent manipulation anesthetic for frozen shoulder and had a fracture, was found to have a breast CA with a metastasis in the shoulder. So the pain was because of metastasis, and but it was misdiagnosed as frozen shoulder. So any person older than 75, 80, be very wary when you diagnose it as primary frozen shoulder. Okay. So this is another patient who presented to us with right shoulder, severe right shoulder pain, and this X-ray you can see something there, and it turned out to be a bronchogenic carcinoma. So these are things which you can come to your OPD as shoulder pain. Many times you have actually injected, patient is not getting better. So just don't keep on telling the patient that will be all right. Maybe proceed to get a next further investigation. So the most important thing is to clinch the diagnosis of primary frozen shoulder. So how do you do it? How do I do it? Is 40 to 75-year-old patient walking in, complaining of night pain, no history of trauma, diabetic, okay, other histories. So for me, the clinching diagnosis comes from external rotation. If the patient has external rotation 0 to 10 degree or distension test, I'll tell you what is distension test, and the normal X-ray. So it's most likely frozen shoulder. Okay. So this is an important paper. All of you, I would like you to read this paper. This is from Sugaya. So here they looked at rotator cuff lesions in patients with stiff shoulders, and they found any patient who had 0 or less than 10 degrees of external, they had no problems with their cuff. The cuff was normal. But any patient who had more than 30 or 40 degrees of external like this, like that, so those patients actually had partial thickness cuff tear or full thickness cuff tear. So one thing you can be sure, if the patient has 0 or 10 degrees or less than 10 degrees of external is that this patient is primary frozen shoulder. Obviously, the X-ray has to be normal. It could be OA also. It can be osteoarthritis also. Severe osteoarthritis will not have any extension. So this is a paper you should go through. Now, distension test. This was an interesting test. I visited Samuel Antuna in Madrid. He showed me this test. So in early frozen shoulder, you will have a little external rotation, but this is what you call as distension, because it's not, you can call it any which way you want. So you take the patient to the maximum external rotation possible, and then you give a sudden jerky movement, just more than the patient's external rotation on that side. So that will cause severe pain for the patient. I'll show you in a video later. So this is again a sensitive test in a patient with early frozen shoulder where you have external rotation, but you suspect it is frozen shoulder. This test is very sensitive. This test is only false positive if there is OA or subscap tendinitis, which is rare. Subscap tendinitis, a big calcium sitting there, that can cause this. But otherwise, this is another test you can employ in your daily regular practice to actually diagnose or rule out frozen. So elevation possible, rotation is restricted. So it is frozen shoulder or shoulder glenoidal arthritis, posterior dislocation of shoulder. We've seen patients who are missed. So rotation is not possible. External rotation not possible. Elevation painful and restricted. Rotation is possible. Calcific tendinitis. These are things you need to keep in mind. Any patient coming with acute shoulder pain, starting from the afternoon, getting worse at night, unable to sleep, early morning presenting to your OPD, that's a patient with calcium. You get an X-ray, you will see that. So that's posterior dislocation, this calcific tendinitis. So posterior dislocation also is something. Yeah. You can stop me anytime if you have any questions.
Yeah, please continue.
So next thing is, so by now I think you ruled out frozen shoulder in the patient. Okay. Next thing is cuff tendinosis, bursitis. This is not full thickness cuff tear. This is a patient who has pain in the subacromial area. So this is the patient we usually confuse with frozen shoulder. So when the patient has normal external rotation, and impingement is positive. You do impingement test, it is positive. This is a patient where I suspect subacromial impingement, something happening in the subacromial area. It could be a bursitis, it could be a, rotator cuff tendinosis, or all sorts of rotator cuff pathology. Full thickness tear, obviously you will have weakness. Now this patient, you put them through the impingement drain, they'll have pain, but they might not be weak. So this patient might have a small full thickness tear, a single tendon tear, that can still present in patients who have strong shoulders. They've got good deltoid, they got good compensated shoulders. They might still present with only pain, a single tendon supra tear maybe. But most of the time, this tendinosis patients, they present with symptoms like this. Pain on elevation, not on all ranges. Pain is only on elevation or certain angles. They'll come and tell you. Pain is at night, obviously. This is similar to frozen shoulder. But next thing is external rotation will be full, or it will be slightly reduced compared to the opposite side. It's not like the PA shoulder where it is grossly restricted. Impingement test will be positive. Cuff power might be normal or slightly reduced depending on the pain of the patient and how you test. So this is tendinosis, bursitis. Why this is important for me is, for this patient, I'll give the injection in the subacromial area. I give an anterolateral, like how you make your anterolateral portal, I put my injection there into the bursa. So the bursa is anterior to the acromion. The bursa is not underneath the acromion. It is anterior to the acromion. So we'll have to give the injection slightly, directing your needle anterior to the acromion. For a frozen shoulder patient, I give the steroid injection intra-articularly, just lateral to the coracoid, directing your needle straight into the joint through the rotator interval. So this is very important for me because the site of injection decides how much pain relief the patient has. So again, the exercises are totally different for impingement and frozen shoulder. So clinically, I have to make this distinction before I start treatment. So that's very important. Next comes cuff tear. Cuff tear is straightforward. Patient, you divide cuff tear into anterosuperior cuff tear and posterosuperior cuff tear. Keep this in mind. Isolated supra tear, rarely symptomatic. Patients come only with pain. They might improve with exercises. You might not progress to MRI most of the time. So isolated supra tear patients coming with pain, they might settle down even with nice cuff and scapula strengthening exercises. So usually patients who have pain and weakness, they usually have a anterosuperior tear, which means supra and subscap, or they'll have supra and infra, posterosuperior cuff tear. So these are things you need to keep in mind. Now, this paper again, I want you to read. This is Philip Colling's paper in CORR. So this is how you classify cuff tears, but then what this is testing for teres minor. I'll show you. So this is the normal test I do, nothing different. I check for supra strength, infra strength, and obviously subscap. You have the belly press and the lift off. So lift off you can't do in patients who have restricted internal rotation. So we do belly press. These are things which you should not miss. Subscap, many times the MRI does not report. So you'll have to do the test and see. A patient with a full thickness subscap tear, definitely belly press will be positive. So lag sign is very important. When you're coming across a patient with a massive cuff tear, the lag sign again is very prognostic. Now, what does lag sign show? ER lag. ER lag basically shows tear in the teres minor. So what is ER lag? This is ER lag. So ask the patient to actually, you can do it either way. I actually do it like this. I ask the patient slightly flex, slightly abduct, and externally rotate and keep and maintain the shoulder there. So the patient will not be able to maintain, will just fall back. So that is ER lag. So so something like this is a very old video, but so the patient will not be able to maintain the external rotation. So what does this indicate is, this indicates that the cuff tear has progressed all the way to the teres minor. Okay, the cuff tear has progressed all the way to the teres minor. Now, when teres minor is involved and ER lag is there, and say in the MRI you got significant atrophy, now then you have to think about what you're going to do. Your tendon transfer might not work. Hope if your muscles are good, they are not atrophied, then you have to make sure that you repair that most posterior part of the cuff with an anchor at the just next to the bare area. Just next to the bare area, you put one anchor and secure the teres minor there. Otherwise, you're not going to have any external for the patient. So external is the most important movement for any patient. Why is that important? Why is external more important than abduction? Who is there? Jyoti? Sanjeev? Anybody?
So, sir, external rotation by the supraspinatus and abduction by deltoid muscle, sir.
Now, which movement is important? Elevation is important or external rotation is important?
Sir, for supraspinatus, external rotation is important, sir.
No, if you ask the patient which movement is important, the patient will prioritize external rotation because external rotation lets you keep the arm in space. If you want to hold the arm in space like this, you need external rotation. So if you don't have external rotation, the arm will fall back. If you are sitting on a table, if you have to take a tumbler or a dish from the dining table, there is no external rotation, patient can't do it. So external rotation is very important, and teres minor is very important for that. So if teres is gone, so you have to warn the patient or counsel the patient accordingly. So always look for external rotation lag sign. That is something you should always look for in all cuff tear patients. So external lag sign, as I showed you, that's forward. These are the other signs. Dropping lag sign are the other signs. Lift off, all of you know. So this is about cuff tear. So cuff tear, elevation of the arm. You see how much the patient elevates. Weakness in abduction, you do strength testing for supra. Weakness in external lag, and don't forget. Now comes the instability part. So instability, as I told you, I include a lot of things in instability because I think instability has a part in all these things. So traumatic instability is straightforward. Patient will come and tell you the shoulder dislocated, or you did the reduction for the patient, and there is a patient comes with an MRI showing a labral tear. The traumatic instability is easy to diagnose, easy to counsel and do surgery. That's a different thing. But clinically, young patients coming with impingement-like symptoms, coming with biceps pain, coming with pain around this area, these are all patients with subtle instability. Now, by instability, I don't mean glenohumeral instability itself. Of course, there will be a component of glenohumeral instability, but there is always capulothoracic and other muscles around the shoulder which are weak and not in coordination. So this is for your routine traumatic instability. These are the things I do. Of course, for posterior instability, I do the crank test. Crank test basically adduction, internotation, and push the shoulder. Give axial thrust. So that will give pain to the patient. Posterior shoulder instability patients don't come with instability symptoms. They will not come and tell you that the shoulder dislocates. They will come and tell you there is pain on front loading. If you load the patient, say if he's doing a bench press or a chest press, there will be pain in the back of the shoulder. These are patients with posterior or multidirectional instability. Okay. So young patient with impingement-like picture, it's almost always instability. So look at the scapula, rule out winging, scapular dyskinesis, do O'Brien's. It might be slap, anterior labral tear, internal impingement. Mostly correctable with exercises. But if there is a structural lesion, if it is not responding to exercises, then you get an MRI, and if you see a tear, then unless you fix it, it's not going to improve. You have to fix it. So this is just a normal patient walking in shoulder pain. You just take the shirt off and ask him to do a elevation. You immediately realize that his left shoulder is not normal. This is say at rest, his shoulder is high up. The normal shoulder is drooped. That shoulder is looking up, and his scapular rhythm is all haywire. It's going all over the place. So this is something you need to observe. And all the young patients take their shoulder off and ask them to do repeated movements of their repeated elevation movements, not forward elevation, just sideways elevation. So ask them to do it. You ask them to do it 10 times, not one time. Do it 10 times, then the muscles get a bit fatigued, and then it will show the exact extent of their scapular problem. So only when they do it 10 times and the scapular rhythm is perfect, I get convinced that it is not a scapular issue. So whenever a patient comes with shoulder pain, I definitely look at their posture. Now, most of our patients have posture problems. So all the trapezial triggers and the scapular trigger, you correct the posture, you give them proper exercises, they become better. This is something which you need to note down in your clinical OPD sheet and then send it. Ask the physio to do specific exercises to correct the posture of the patient. Now, why posture is important? Because if the way you are standing straight, your capsule is taut. So the capsule does all the work to hold your shoulder in place. But when you are drooping, the capsule is loose. So the cuff has to overact to actually hold the shoulder in place. So the cuff becomes fatigued very soon. That is why posture is very important. So this is Yanda. He's a very well-known Czechoslovakian surgeon. So this is called the upper cross syndrome. This is, I think most of our IT professionals, any person who is using mobile phones are all affected with this upper cross syndrome. So you got overactive upper trapezius and levator, and your deep neck flexors, and your scapular stabilizers, especially the serratus and lower trap, are very weak. So this is something which you need to keep in mind whenever you see a patient. So the serratus anterior and lower trap has to be strengthened. So dyskinesis can lead to labral injury. Any patient who has dyskinesis, it's a prodrome. It is like a first step in the injury pattern. So any patient who comes with shoulder pain, if you diagnose them before and treat them properly, then they escape a structural lesion. Otherwise, they will always end up in a bank cut or a labral tear. and then you'll have to go and fix it. So that's very important to notice very early. Now, this is another paper which I'd like you to read. This is Aaron Siaska's paper with Ben Kibler. So this is again available free. So this is the algorithm which they give. It's a little busy, but it's very, very easy. Very easy. So any patient with shoulder pain, you rule out scapular dyskinesis. If scapular dyskinesis is present, how do you confirm it? You do the scapular assistance and the scapular retraction test. I mean, you can do the scapular assistance test. I do only that. Any patient who has a protracted scapula, I just assist the scapula and then ask the patient to raise the hand up. The patient has relief of symptoms, then we go ahead and start strengthening their scapular muscles first. Now, the most important thing they are talking about is the serratus anterior lower trapezius insufficiency. Oh, I get the point. Other most important thing is we are talking about is the hip and the core weakness. So many patients who have gluteal weakness can have shoulder issues. So any patient, there is a test called the low road test for that. I'll show you. Then obviously you can look for scapular muscle weakness. Any organic cause for scapular problems like a clavicle fracture or a sternoclavicular joint arthritis, instability. These are things which you have to rule out as well. And loss of conscious control. All patients who have instability, all patients who have voluntary instability. These are also patients whom you have to diagnose and treat accordingly. Now, the most important muscles which are tight, which you have to look for, is the pec minor and the upper trap. So keep all these things in mind.
Yeah.
Scapular assistance test, I do it, and this is the low row. On the left side, you see the low row test. Basically, you stand straight, extend your arm a little bit, and then you try to take it to flexed position first. And then next time when you take it to flexed position, try to contract your gluteal muscles. When you contract your gluteal muscles, if you can do it better, that means you have to do, you have to strengthen his hip and gluteal muscles as well, and the core muscles as well. So this low row and scapular assistance will help you to diagnose what the problem is. So this is something, this is the algorithm. I think I'll share the paper to you. All of you read this paper. It's very, very important. So look for tight muscles, look for the weak muscles. Usually the pec minor and upper trap are tight. Serratus and lower trap are weak. So these are muscles you have to look and work accordingly. Of course, a malunited clavicle fracture on AC joint dislocation can cause shoulder pain, which needs to be corrected. So this is a patient, 20-year-old female, difficulty in overhead abduction, several consults for shoulder pain, physiotherapy, subacromial steroid injection. This is the patient. That's the range she has. And you can see that the scapula is running lateral and it's going down when she lifts the arm. Okay. So on further examination, actually, can you see that the scapula is actually not staying in place? It has gone down and it has gone more lateral. So this is lateral winging. This is spinal axillary This patient had a cervical node biopsy, which actually injured her spinal axillary nerve and she didn't recover at all. So this is again, you can't miss. This is very rare, but still we've seen few patients like this running around here and there, getting all sorts of treatment. This is a triangle sign. The patient on the unaffected side, she is able to lift the arm up, without any problem. She can lie down and lift the arm, whereas on the affected side, she cannot lift the arm. Her trunk has to go up. She cannot lift if you ask her to lift the arm. So that's the triangle sign. So this is the diagnostic test for your lateral winging. Okay. So this is something also you need to keep in mind, winging of scapula, which is rare, but as a shoulder surgeon, these are things which you cannot afford to miss. So this is my fast track examination.
Yeah. So first we start with the pain movement. Check the normal shoulder.
So always check the normal side first. I check for passive range mostly.
Check for passive extension.
So she's got reasonable extension, 90, almost 90 degree. That is the impingement range I think. Now that's the affected side.
That's the PO.
When you do the externalization from the back, the patient will tend to turn towards your side. So make sure the patient stands straight. That's only 10 degree, nothing more than that. That's also very painful. Lot of pain. So global restriction of pain. Now I'm testing for muscle strength. So muscle strength can be tested well within the range of the patient, no matter what the range is. I don't know how to mute. So that is done. That is about 30 seconds, and we already know the diagnosis of this patient. So what is the diagnosis here?
PA.
Frozen shoulder, yes. So it's just straightforward because you check for muscle strength as well. The strength testing is very easy. This position can test your supra strength, and then infra can be tested very easily, and subscap also can be tested. So patient has global restriction of range, severely painful, ER is very less, and distension test is positive. So all this took about 30 seconds, and this patient gets a glenohumeral joint injection if the patient has a night pain, and exercises to stretch the shoulder capsule. So I think that's it. So these are the diagnostic clusters I talked to you about. So I would like to leave you here, and I'm ready for any questions.
So any questions from the fellows? And I welcome all of you whom I didn't introduce in the beginning. But please ask questions, because if you ask questions, it will be better for everyone's understanding. Jyoti, any questions?
No, sir. I understood everything, sir.
There are many tests like special tests and examinations. So you Karthik, can I ask one?
Yeah, please, sir. Go ahead, sir.
Just to stimulate the discussion.
Yeah.
But do you do all the tests, or you rely on imaging also, or you're completely imaging is just to confirm your findings? I'm talking practically what you do in your day-to-day OPD.
So as I told you, the patient comes with shoulder pain to me as a first visit. Now I do this whatever the fast track examination of what I showed you. I do the examination. I get an X-ray, plain X-ray, and I come to a working diagnosis. So the diagnosis can be, as I told you, frozen shoulder or bursitis, subacromial impingement. If I suspect a full thickness cuff tear, and the cuff tear is significant in the sense the patient has severe weakness, then I'll go ahead and suggest an MRI for the patient. Otherwise, for the impingement and the frozen shoulder group, I just go with only the X-ray and the clinical findings, and we proceed for treatment. Now, when it comes to special tests, so the special tests are done mostly in the instability group. Whatever I have clustered into the instability group. So those are patients. If there is a clear-cut traumatic instability, you don't need any other tests. So if you want to diagnose SLAP, say if you think the patient has shoulder pain, vague shoulder pain, young guy, weightlifting, gym guy, and your maybe your O'Brien's is positive. You do O'Brien's, so I do O'Brien's. When the patient got no pain here in this level, then I do O'Brien's. O'Brien's is positive. He's got a little bit of scapula, trapezius trigger, probably his pec minor is tight. So I just keep that in my mind. I tell my physio that this is what I'm thinking about, and I also tell the patient that there could be a small tear in your ligament, but I want to try physio because I'm not going to operate on this patient straight away. I'm going to do physio for him, and if his physio doesn't improve, so my criteria is my working diagnosis if it remains as, say, a superior labral tear or a non-traumatic instability patient. So what I tell the patient is that there should be 50% improvement in your symptoms So if you're unable to throw, if you're unable to bowl, if there's pain on activity, then there should be 50% improvement in symptoms with the physiotherapy at 1 month. If you do the physio properly. If there is no improvement in function, then I will proceed and do a imaging. That's what I tell the patient. Because
Can I ask a question?
imaging might not help as well many times, because many times a slap is not diagnosed on imaging. So sometimes we have gone with almost the normal reports, and then we have found huge tears. Both anterior and posterior. We had 2 patients recently. Just last week we had 2 patients. Yeah. Who's
Yeah,
going to
I agree with you, Karthik, because many times imaging will give you extra diagnosis also, extra findings. And
yeah, which may
sometimes
not
you don't know which one to give more importance. So
Yeah.
the examination we cannot skip, like clinical examination we cannot skip, because MRI might tell you like 3 or 4 differential diagnosis. Then again you have to come back to examination only. So you should have a working diagnosis, plus you should have a good relationship with your radiologist, so that you can pick up a phone and discuss what you feel, and they should rule out what you feel clinically and whether it is there or not. Akram, you want to say something?
Totally agree.
Yeah, I just want to echo what Karthik said. I think clinical examination is paramount in any shoulder diagnostic test. I mean, imaging only subserves your clinical diagnosis. It most of the time confirms your clinical diagnosis, but we must rely to entirely not on clinical diagnosis. Sometimes, yes, we should do a diagnostic test also.
One thing which clinically we can't confirm is a sphenoglenoid knot cyst. If it is,
Yes.
it has not caused neuropathy, and if your infraspinatus is not completely wasted, then that is something which we can miss. So patient who is not responding to physio for more than a month, no improvement at all whatsoever, pain is persisting, then I go and do a MRI. So, but patients who are responding, then I tend to wait. Many times, young guys, sportsmen, weightlifters, they are not coming to us for surgery. They want to fix their problem, mostly with exercises. Even medicine, they are hesitant. So these are patients whom I treat them with exercises, and if they're not improving, then I tell them probably you should go for a MRI next. So
Karthik, any particular examination thing for LHB tendinitis?
I look for groove tenderness, sir. Groove tenderness is my only. I just rely on that because for me LHB tendinitis is secondary. It's not a primary problem. Now LHB tendinitis primarily can happen rarely. Mostly it is secondary to some sort of overload to the biceps, which is coming either from the labrum or from the cuff. So if either cuff is weak or labrum is torn, then biceps is getting overloaded. That is when LHB tendinitis develops. So you correct the primary pathology, LHB tendinitis alone, it's a little rare. So nowadays, earlier we used to be very, very particular about long adduct biceps, but nowadays we're not very bothered about it. Most of the time during cuff repair, we don't cut it also. We just leave it. And if it is
even in more than 55-year-old patient, and you can think it as a cause of pain later on if we have repaired a cuff.
Yeah, if it is looking healthy, I wouldn't cut it, because 55-year-old farmers, 60, 70-year-old farmers, they come and complain that they got a Popeye and they are having this and that. They'll say this arm is not looking like that arm. If it is not, say for the long adduct biceps to be stable, you need the medial pulley and the lateral pulley. So if the subscap is intact, your medial pulley is, the superior glenohumeral ligament is intact, subscap is intact, medial pulley is there. Lateral pulley is basically formed by the supra. Suppose the cuff tendon is perfect, the LHB tendon is very nice, shiny, healthy, and you repair the supra, the tendon is not going to slip anywhere, it's not going to cause any pain. This whole French idea of the LHB tendinitis to be a pain generator, I think it's not appreciated so much anymore. So we can safely.
So tell me, what percentage of a frayed, say, bicep center would you do tenotomy and do a tenodesis?
No, the thing is, I would, if I do a tenotomy in a say 55 or a 60-year-old male, then I would tend to do a tenodesis. I would just include that biceps, do a juxtaarticular tenodesis. But if it is healthy, I would just leave it. It doesn't matter which it. I mean, it depends on the case. There is no If you have a badly damaged biceps, it is all flattened and it is all shredded, then I cut it. Tenotomy.
And cut it and then repair it, do tenodesis or just start it?
Tenotomy.
Tenotomy. Okay.
I don't do too much of tenodesis, sir. But I don't do too much of tenodesis. The young patients, I do subpec tenodesis. But
anyone else want to ask anything?
I have a question, sir, if you may allow me.
Yes, Ankit, welcome.
Yes. Sir, a very small question regarding to the bicep tendinitis. For examination, which test do you suggest which is more specific or sensitive in that matter? Because usually we go about Yergatsen and speed test. Do you reckon the uppercut test, which is most often said in the newest literature that it is more sensitive, that we can delineate the pathology of the bicep tendinitis?
Ankit, as I told you, I look for groove tenderness. For me, if you put your finger here in the bicipital groove and the patient is tender, you put your finger on the other bicipital groove also. So always compare it to the normal side. So if there is pain here and my O'Brien's is positive, then I go with, I used to do the speeds test. I don't know what you mean by the uppercut, but as I told you, biceps for me is not of a big concern now. Now, if I biceps tenodesis isolated surgery, we don't do. There is always something else to the patient. So what the biceps has to alert you in a young patient is the patient might have something else. He might have a posterior superior labral tear. He might have an anterior inferior labral tear, or he might have a pasta lesion. Something is causing the biceps to get irritated. So that is the thing. So if you only fix the biceps, he might not get better. So I'm not worried much about it. Yeah.
Okay. Thank you, sir.
So if no one has,
Okay.
thank you, Karthik. Thank you, Karthik. It was really nice.
I can see Shreyas here. Shreyas has joined from Mangalore, and Hariharan is from he's from Neyveli, and so all these are our ex-fellows. Shreyas, Hariharan, and Kaushik. You are with my super seniors here, Dr. Vikas Gupta and Dr. Akram Javed. They taught me all that I know, so so you have to thank them all.
Now we are in a learning group.
And, so nice to see. I also not seen them for a while, so they all left us a little time back. So nice to see you. Thank you very much. Thanks for the opportunity. Any other questions?
Thank you, sir. Thank you.
I can send you all the papers I just mentioned. I might just share it with Vikas sir. You can all.
Yeah, we can share it on a group, and we have a group. We share our papers on this group. Academic group is there.
Okay,
So
I'll send those papers.
yeah, if you send me, I'll share with all of them.
Okay.
So thank you, Karthik. It was really nice listening to you. You are again very thankful. You're taken your time from busy schedule. Thank you.
Thank you. Hope I did some justice to the topic. I just don't.
No. It's good. It's good. We'll continue with this. Maybe we'll have another talk on not on the same topic. Going further from here.
On all this, like scapula and other things. There is so much.
Yeah. Further from here. And thanks a lot. It was good. I hope everyone has enjoyed it, and definitely I enjoyed it, and I learned few tricks. Thank you. Thanks a lot.
Thank you. Bye-bye.